Hi, today we are going to basically concentrate on image based questions. The images that are going to be frequently asked in your entrance examination. Right? Get ready for these images. So, today is image based in pediatrics. Right. Okay. Let me start the first image. Look at this. What is this? Is this clitoris? Look at the genitalia. Tell me whether the child is a boy or girl. Whether the child is a boy or girl, can you please, what is this called as? What is this called as? This is, you can't say whether it is a boy or girl. This is called atypical genitalia. The new term is called atypical genitalia. Old term is called ambiguous genitalia. Another old term is called as hermaphrodite. Do not use the word hermaphrodite. Do not use the term ambiguous genitalia. Please use the term atypical genitalia. We don't know whether it is a under-virilized boy or a virilized girl. Whether it is a under-virilized boy or virilized girl, we really don't know. Whenever we see these atypical genitalia, unless otherwise proved, it is a case of congenital adrenal hyperplasia. I repeat, it is congenital adrenal hyperplasia. There are so many enzymes involved in congenital adrenal hyperplasia. And this is a revision class basically. So let me cover the important enzymes and the functions and the manifestations of congenital adrenal hyperplasia. Okay, if anyone, if you want to answer, you can answer, no issues. Right. Right. So the most common is 21 alpha hydroxylase enzyme. The most common is, so you know what are all the manifestation in boy, what are all the manifestation in girl, and what is the manifestation with respect to BP. Right. In 21 alpha hydroxylase, what will happen in boys? Boys usually get precocious puberty. Boys usually get precocious puberty because there is excess testosterone. Girls usually has got atypical genitalia. P stands for precocious puberty and AG stands for atypical genitalia. What will happen to BP? BP will be low, hypotension. BP will be low, hypotension. The next one is 11 beta hydroxylase deficiency. Here also, boys will get precocious puberty. Boys will get precocious puberty. Girls will get atypical genitalia. What will happen to BP in this condition? BP here is high. So this is hypertensive. This is hypertensive. Right. Now comes 17 alpha hydroxylase and 1720 lyase. 17 alpha hydroxylase and 1720 lyase. So what happens in case of 17 alpha hydroxylase and 1720 lyase? In these two conditions, you will get atypical genitalia in boys. You will get atypical genitalia in boys. Girls will have normal genitalia. Girls will have normal genitalia. And the BP often will be high. BP will often be high. Often be high. So this is with respect to BP will often be high. This is with respect to 17 alpha hydroxylase and 1720 lyase. So tell me, what is the investigation of choice? What is the investigation of choice in these conditions? Tell me, what is the investigation of choice? The investigation of choice in majority of these conditions is elevated 17 hydroxyprogesterone. So 17 hydroxyprogesterone is the screening test of choice. 17-hydroxyprogesterone is the screening test of choice. If mother tells you history that one child had been affected, previous child had been affected, now she is conceived, means how to prevent virilization of that female fetus that is growing inside. Simple, you need to give maternal dexamethasone. You need to give maternal dexamethasone. Dexamethasone till delivery. Till delivery, if it is a girl child. Till delivery, if it is a girl child. Girl child. That's all. These 5 points are more than enough. In 21 alpha hydroxylase and 11 beta hydroxylase, precocious puberty in boys and atypical genitalia in girls. Whereas hypertension in case of boys, in case of 21 alpha hydroxylase, and hypotension in case of 21 alpha hydroxylase, and hypertension in case of 11 beta hydroxylase. In 17 alpha hydroxylase and 17-20 lyase, girls will have normal genitalia, whereas boys will have atypical genitalia. Again, BP here will be high, hypertension. Use the term atypical genitalia rather than pseudo-hermaphrodite or ambiguous genitalia. These disorders are classified under congenital adrenal hyperplasia. Investigation screening test of choice is serum 17-hydroxyprogesterone levels and how to prevent the next child from getting virilization. If it is a female, give maternal dexamethasone as soon as the mother gets conceived, and you need to continue till delivery. Maternal dexamethasone. All these 5 points are very, very important. Definitely you will crack one question if you understand the concept, or else you just remember this fact, right? If possible, you try to answer, my dear boys and girls. Okay, then next question. So what is the next question? So what is this? Can anyone tell me what is this test is called as? Can anyone tell me what is this test called as? Look at this. One hand is the child, one of the hand on the right side. The right hand is immersed in the water, whereas the left hand is not immersed in the water. There is exaggerated wrinkling. There is exaggerated wrinkling on the right hand. So what is this test called as? Exaggerated wrinkling of the right hand when immersed, whereas the left hand is normal. What is this investigation called as? Can anyone tell me? Can anyone answer in our chat box? Okay, so this is nothing but aquagenic wrinkling test. What is this test called as? This is called as aquagenic wrinkling test. This test is called aquagenic wrinkling test. That means if one hand is immersed in a bowl of water and another hand you use it as a control, and for each and every minute you take the hand which is immersed in water, for each and every minute take and then observe. If there is exaggerated wrinkling of the hand which is immersed in water, particularly if it occurs less than 3 minutes, this is called aquagenic wrinkling test positive. This is the screening test for cystic fibrosis. So this is the screening test for cystic fibrosis. This is the screening test for cystic fibrosis, and the cutoff value is you get an exaggerated wrinkling within 3 minutes. Wrinkling within 3 minutes. What is the investigation of choice for what is the confirmatory test for cystic fibrosis? Sweat chloride test. Sweat chloride test. What channel is affected? What channel is affected in cystic fibrosis? Chloride channel. Chloride cannot be secreted into the duct. Chloride channel, right? What are all the organs affected in cystic fibrosis? Mainly Three organs, mainly respiratory tract, reproductive tract, and then what is that? A intestinal tract. But basically, for an intern, for a PG aspirant, two things. One is lung, another is pancreas. So you two main organs that are affected is lung, leading to bronchiectasis. And then you will get pancreatic insufficiency. Pancreatic insufficiency. Other than that, you can get chronic liver disease. You can get complete absence of bilateral vas deferens. Complete absence of bilateral vas deferens. Vas deferens. So what are all the drugs used? Can anyone tell me what are all the drug used? The drug which acts on the CFTR receptor. The drug which acts on the CFTR receptor. One such drug, 𝐒𝐻𝐿𝐴𝐻𝐿, 𝐒𝐻𝐿𝐴𝐻𝐿 or 𝐒𝐿𝐴𝐻𝐿. 𝐒𝐻𝐿𝐴𝐻𝐿 or 𝐒𝐿𝐴𝐻𝐿. Okay, drugs used. And tell me too, with respect to cystic fibrosis, what is the most common infections that can lead to chronic colonization in the lung? Two things. One is Pseudomonas colonization in the lung because of biofilm formation. Because of biofilm formation. The next one is Burkholderia cepaceae. Burkholderia. Next one is Burkholderia cepaceae. Okay, right. So the test is called aquagenic wrinkling test. It is the screening test for cystic fibrosis. The exaggerated wrinkling within 3 minutes should be taken into account for a positive test. Chloride channel is affected in case of cystic fibrosis. Reproductive system, respiratory tract, intestinal tract are all affected. Sweat chloride of more than 60 millimole per liter is termed as positive. Drugs used are 𝐒𝐻𝐿𝐴𝐻𝐿, 𝐒𝐿𝐴𝐻𝐿, etc. And the most common organism is Pseudomonas colonization in the lung. But the most common organism which can lead to death is Burkholderia cepaceae, and the syndrome is called as Cepaceae syndrome. Okay, and the syndrome is called as what? Cepaceae syndrome. Right. So first, atypical genitalia, congenital adrenal hyperplasia. Second one is small points on cystic fibrosis. This is called aquagenic wrinkling test. Right. Third, so what is this? What is this? Can anyone tell me what is this? So let me say the child has been suffering from, okay, the child has been suffering from what do you say, fever and weight loss for more than 2 weeks. So what should be the answer? Fever and weight loss for more than 2 weeks. So what should be the answer? Weight loss for more than 2 weeks. What should be the answer, my dear boys and girls? Tell me. Whenever anyone who is having fever and weight loss for more than 2 weeks, particularly in India, you need to consider tuberculosis. What? Tuberculosis is the first diagnosis, and here you could see a hilar adenopathy. You could see a hilar adenopathy. What are all the TB specific X-rays? 3 findings with respect to TB. What are all the 3 findings? So the 3 findings with respect to TB are anyone. What are all the TB specific X-rays? So the 3 findings are one is cavity. You have one more video, one more image that I will show you. Cavity is TB specific. Second one is hilar adenopathy. Hilar adenopathy. Third one is miliary pattern. Third one is miliary pattern. When these 3 things are present, it is suggestive of TB. So what you need to do, whenever any child is brought with fever of more than 2 weeks and a cough for more than 2 weeks, take an X-ray to look for these 3 findings: cavity, hilar adenopathy and miliary pattern. If any one of these are present, So it is TB specific. If any of these X-ray findings are present, then you need to do sputum. Then you need to do sputum CB0 cartridge based nucleic acid amplification test. It will show whether MTB detected or not, whether R resistance detected or not. MTB detected or not and R resistance detected or not. So now you have a case in which fever more than 2 weeks, cough more than 2 weeks, but cavity, hilar adenopathy, miliary pattern is not present. Now what will you do? In this scenario, you need to give a trial of antibiotics. You need to give a trial of antibiotics, but that antibiotic should not include levofloxacin and linezolid because they are active against TB and it can lead to false negative result whenever you do a CB0. Whenever you do a CB0. So, right. Third point. Fourth point. So, what is the point of care test in case of TB as we discussed already? What is the point of care test? The point of care test is sputum. Sputum means what are all the sample? Gastric lavage. Second one is, what are all the other things? One is gastric lavage. Second one is expectorated sputum. Third one is induced sputum. With that, you need to do CB0. So CB0 is the point of care test. Cartridge based nucleic acid amplification test, otherwise known as gene expert. So this is the point of care test. But what is the investigation of choice to detect tuberculosis? Can anyone tell me what is the investigation of choice? The investigation of choice is MGIT. MGIT. What is called MGIT? MGIT is liquid culture. MGIT is liquid culture. What is the expansion for MGIT? Mycobacterium growth indicator tube system. That is MGIT. MGIT is a liquid culture medium. Don't say LJ medium, Lowenstein, which is solid medium, which takes 48 days for the results to get. But right now, with the help of MGIT, either you can get result within 9 days or 42 days. So it is easy to get a result and it is gold standard for diagnosis of tuberculosis. Then, what are all the indirect tests you have? The indirect test means they detect infection. So, what are all the indirect tests? Indirect test means detect infection, not bacilli directly, detects infection. So, what are all the three indirect tests you have? One is Mantoux test. Second one is IGRA, interferon gamma release assay, that is otherwise called as quantiferon gold test. That is quantiferon gold test. The third one is CTB test. CTB test. So in Mantoux is a skin test. CTB is a skin test. Mantoux you use PPD, purified protein derivative, which is not specific for Mycobacterium tuberculosis, whereas in CTB test you use ESAT, CFP. These are TB specific antigen, so this is specific. So both Mantoux and the CTB test both detects infection and not disease. Mantoux is not specific because you use purified protein derivative, which is present in both typical and atypical mycobacterial infection, whereas CTB test is also a skin test resembling your Mantoux, but you use ESAT and CFP protein, which are specific for Mycobacterium tuberculosis. And what is the only blood test? What is the only blood test that you do with the TB? Simple. The only blood test that we saw right now is IGRA. interferon gamma release assay, otherwise known as quantiferon gold test. This was asked once in AIMS. Okay, that's all. So what are all the points that we gather in this image? Whenever you have fever and cough lasting for more than 2 weeks, it is suggestive of tuberculosis. Take an X-ray. If X-ray reveals what is that, hilar adenopathy, cavity and miliary pattern, it is suggestive of TB. Then proceed for sputum CB0. If X-ray is not suggestive of those three findings, then you need to give a trial of antibiotic. What is the point of care test? Point of care test is gene expert or CB0. But what is the confirmatory test of choice? MGAT, which is based on liquid culture medium. Indirect tests are two skin tests. Manto, not specific. TTB test, specific. Only blood test for to detect infection is IGRA. Good. Right? Revision over with respect to TB. So this is a case of hilar adenopathy suggestive of TB. Can anyone tell me what is this? Many are watching now. You tell me what is this. What is this? There is a HR. So I told the answer now. There is a HR in the inguinal fold region. What is the disease we are dealing with? So this lesion is called HR. This lesion is called HR, which is usually painless. That's why it is often difficult to find out what organism it is. It usually occurs in scrub typhus. Occurs in scrub typhus, and it is through mite. Okay, the area where mite enters the body, mite. Drug of choice is doxycycline, if not azithromycin, but the preliminary drug of choice is doxycycline. So what is the investigation of choice? Investigation of choice is IgM ELISA for scrub typhus. That is the test we used to do now. IgM ELISA for scrub typhus. What is the pathophysiology? Pathophysiology is vasculitis, and they produce thrombosis. What is this lesion called as? The HR, the other name of the lesion is called as what? Tachynoir. What is that lesion called as? Tachynoir. Painless HR. I repeat, painless HR. Old test is Weil-Felix test. Old test is Weil-Felix, which we are not using it now. Weil-Felix test. The new test, as I told you already, IgM for ELISA. Drug of choice is doxycycline. Okay, scrub typhus, it is called what organism? Tsutsugamushi. Okay, it is caused by Tsutsugamushi. Remember, very important, the most common skin infection associated with the fever, hepatosplenomegaly and pancytopenia with elevated CRP. When any skin lesion, particularly painless and involving your scrotum, penis, inguinal fold, vaginal fold, axillary fold, behind the ear, these are all the sites of mite bite. I repeat, these are all the folds are the main areas for mite bite. So whenever any case scenario is given with respect to fever along with a skin lesion involving in any of these folds, it is scrub typhus unless otherwise proved. It is mite borne and caused by Tsutsugamushi. Drug of choice is doxycycline. Investigation of choice is IgM for scrub typhus. Okay, right. Okay. PDF will be shared to you, don't worry. So tachynoir, painless ulcer. Next, so what is this? A boy with recurrent infection. What is this finding? If you chat in the live session in YouTube, it will be more interactive. No, whether it is wrong or right, you just post your answer in chat box. I'll be happy then to share so that I can make what you are thinking in your mind. So based on which we can change our pattern of teaching. So what is this? Boy with recurrent infection. So this is, what is this? Red blood vessels. What is this? Red blood vessels. Enlarged red blood vessels are seen in conjunctiva. So what is this? This is conjunctival telangiectasia. Now you tell me what is the answer? This is conjunctival telangiectasia. So what is the answer? This eye finding is telangiectasia. Telangiectasia. Conjunctival telangiectasia. Presentation. Usually they present with ataxia plus recurrent fever and cough due to bronchiectasis. Due to bronchiectasis. Ataxia telangiectasia, it comes under combined immunodeficiency because combined T cell as well as B cell are affected. T cell, B cell both are affected because ataxia telangiectasia is a disease of DNA repair defect. It is a disease of DNA repair defect. So T cells and B cells cannot repair by themselves, leading on to earlier death of T cells and B cells, leading on to recurrent infection, particularly bronchiectasis. So when any child comes to pulmonology department with a recurrent cough and breathlessness, we invariably see whether telangiectic blood vessels are there in the conjunctiva or not. Then we will take two tests. One test is usually IgA will be very low. The immunoglobulin IgA will be very low, whereas alpha fetoprotein will be very high. Alpha fetoprotein will be very high. And these children are prone for malignancy, particularly lymphoma. Are prone for malignancy, particularly lymphoma. So, infection, recurrent bronchiectasis, telangiectic blood vessels, ataxic or drunken gait, alpha fetoprotein elevated, IgA decrease, prone for malignancy, DNA repair defect comes under combined T cell and B cell disorder. Okay, this is ataxia telangiectasia, that is telangiectic blood vessels. Now, very famous one. Whenever any child with, look at this, whenever any child is presenting with widening of wrist, what should be the answer? Widening of wrist. Look at this, widening of wrist. What are all the findings here? You could see in this image. Look at the image again, right? So what are all the things we can offer in this case? One is cupping of metaphysis, cupping, widening, praying, generalized osteoporosis, widened wrist, as well as one more finding, double malleoli. So these are all the findings in rickets. So look at this. This roughened border is called as praying, and this is enlarged and cup in shape, and it is widened. So widening, cupping, fraying. This is fraying, cupping, widening. This combination occurs developing bone, nothing but rickets. Nothing but rickets. Right? Now, what are all the questions that can be asked in rickets? Remember, rickets can be two things. Rickets can be It can be nutritional or it can be non-nutritional. Nutritional usually manifestation is 6 months to 2 years, whereas non-nutritional less than 2 years. Nutritional will respond to vitamin D supplements, whereas non-nutritional no response. No response. Right? Now, certain questions, the majority of them, because of weak bones, they will present with motor developmental delay, inability to walk, inability to stand, inability to achieve head control, etc. What are all the X-ray findings? So cupping, fraying, widening, osteoporosis. So I repeat, cupping, fraying, widening, osteoporosis. Okay. Can anyone tell me what is the ideal sunlight exposure to get a good vitamin D? The answer is yes. Ideal sunlight exposure. The answer is what? Yes, it is 11 p.m. Sorry, 11 a.m. Good ideal exposure is 11 a.m. to 3 p.m. Ideal sunlight exposure. What is the investigation of choice for a nutritional rickets? The investigation of choice for nutritional rickets is 25 OH-D3, 25 hydroxy vitamin D3, which is the storage form. Okay, so which is the storage form in the liver. Okay, what is the treatment of choice? So old treatment, new treatment. So what is the treatment of choice? Treatment of choice is vitamin D 2000 international units daily into 2 months. That is the treatment of choice, along with calcium, physiological calcium, that is 50 milligram per kilogram per day, vitamin D. Okay, and you need to take a repeat X-ray after 4 weeks. And a repeat X-ray will show one beautiful finding called zone of provisional calcification. So if zone of provisional calcification present, absent. Present means nutritional rickets. Rickets. Zone of provisional calcification absent means non-nutritional rickets. Non-nutritional rickets. Absence means non-nutritional rickets. Okay, what is called zone of calcification? What will happen? This area will have, what will happen? A white line. Because of vitamin D, calcium will be depositing in this area as a thick white line. Thick white line. This is called zone of provisional calcification, which will be usually seen when it is nutritional rickets. Right? When it is nutritional rickets. Right. So this is all about rickets. And any child, when X-ray wrist is given, unless otherwise proved, you can presume that it is a case of nutritional rickets. It is a case of rickets. Okay, cupping, fraying, widening, and generalized osteoporosis. What is this then? Can anyone tell me what is this? And the clue is this is an infant with pancytopenia and hepatosplenomegaly. Infant with pancytopenia and hepatosplenomegaly. So what is this? What is this? Look at this. The bones are very, very, very thick. Look at the bone. Usually bone should have a cortex as well as a medulla. So bone should have a cortex and a medulla. Cortex is the bony part. Medulla is the area where bone marrow is present. So this is cortex. And inside you need to have a medulla. In medulla only you have a bone marrow. Bone marrow, which produces 3 cell lines: RBC, WBC, platelets. What will happen in osteopetrosis? So this is a case of osteopetrosis where this bone marrow is replaced by bone. Bone marrow is replaced by bone. Bone marrow is so there is no medulla. There is no medulla. Okay, so this is called bone within bone. Bone within bone. What is this disease, my dear boys and girls? This is nothing but a case of osteopetrosis. This is a case of osteopetrosis, as a result of which your RBC, WBC, RBC, WBC, platelets all will be low. So you will get pancytopenia along with organomegaly. Which cell line are affected? Then one more question. What is the pathophysiology behind this osteopetrosis? The pathophysiology is, the answer is no osteoclast. No osteoclast. Okay, what is the treatment of choice? Osteoclasts are produced from marrow. They are derived from macrophage. They are derived from macrophage. So what is the macrophage is produced from bone marrow. So what is the treatment of choice? The treatment of choice for osteopetrosis is stem cell transplant. So what is the name given to it? Bone within bone. Bone within bone within bone. So clue, any child with anemia, hepatosplenomegaly, and if X-ray bone picture skeletal survey is given, it is a case of osteopetrosis unless otherwise proved. Right? Then, boy with snoring and sleep disturbance. What is this? Boy with snoring and sleep disturbance. Can you tell me the diagnosis? Boy with snoring and sleep disturbance. Any boy or girl in pediatric age group, if they snore unless otherwise proved, it is a case of adenoid. It is a case of, what is that? Adenoid. You need to take what? X-ray, lateral neck, and it will show what? Look at this. This is enlarged adenoid. This area is enlarged adenoid. Look at this. This area is enlarged adenoid. So what is the treatment of choice for enlarged adenoid? Previously the treatment is adenotonsillectomy. Previously, the treatment is adenotonsillectomy, but the present treatment is intranasal steroids. So, what is the clue for my kids in this case? Any child between 4 years to 9 years or 10 years, if they snore, it is due to adenoid. And the investigation of choice is X-ray lateral neck or nasal endoscopy. The treatment of choice is intranasal steroids. If it doesn't work, then you need to go for adenotonsillectomy. And one more point I would like to add. One more point that I would like to add is respiratory noises. Respiratory noises. Okay, first one is anterior nasal passage. Whenever you have a issue in anterior nasal passage, the sound produced is called as stutter. or snoring, otherwise known as snorting. Snorting. Posterior nasal passage is nothing but your nasopharynx. Just now you saw nasopharynx, that is adenoid. And then you have central airways, central upper airway, central lower airway. Upper airway is larynx. You will get stridor. Most common cause is laryngomalacia. Whereas lower airway is trachea. And it produces stridor plus cough. Cough. Central. Then you have bronchus. The sound produced is wheezing. Produced is wheezing. And finally, your parenchyma. Your parenchyma. Okay, which includes alveoli. And the sound produced is grunting. Grunting. So, what are all the 5 sounds? Stutter, snoring, stridor, wheeze, grunting. These are all the 5 respiratory noises. This case was due to adenoid and it is snoring. Right, look at this. What is this that is present in the lung? Can anyone tell me what is this that is present in the lung? A girl presenting with the hemoptysis, and you could see a mass-like lesion in the lung. What is this? Yes. What is this? This is nothing but hydatid cyst in the lung. This is nothing but, look at this. This is hydatid cyst in the lung. Usually present with cough, fever, breathlessness, hemoptysis, etc. What are all the 2 common species? One is unilocularis and another is multilocularis. Echinococcus. So this is lung hydatid cyst. Investigation of choice is surgical removal of entire cyst. Usually in lung hydatid cyst, albendazole is avoided. You could ask me why albendazole should be avoided. The answer is, whenever you give albendazole for lung hydatid cyst, it breaks and it leads to the release of hydatid cyst antigen, leading to sudden onset anaphylaxis and death. And then, whenever you find hydatid cyst in the body, can I do watchful waiting? Yes, if it is calcified. Calcified means it is died. So if it is calcified, you can wait and watch. If it is calcified, you can wait and watch. Remember, whenever you see a lung along with a cystic lesion in the lung, you need to consider hydatid cyst in the background of the diagnosis, right? So what is this lesion? Can you tell me what is this lesion? What is this lesion, my dear boy? Look at this. Numerous lesions in and around the nose and face. In and around the nose and face. What is the 2 most common organism? This is nothing but what? Impetigo. What are all the 2 types of impetigo or 2 common organism is? One is Staph aureus. Another is group A beta hemolytic streptococcus. What is the 2 most common complications? Staph aureus can lead to staphylococcal scalded skin syndrome or toxic shock syndrome. Staph aureus. Whereas group A beta hemolytic streptococci can lead to what? Can lead to what? Acute glomerulonephritis. Can lead to acute glomerulonephritis. So, what is the drug of choice? If it is folliculitis or pyoderma, it is usually due to Staph aureus, and the drug of choice is cloxacillin or cephalexin. Cloxacillin is active against methicillin sensitive Staphylococcus aureus. So your aureus, right? Which one? Cloxacillin and cephalexin are active against Staph aureus, which are responsible for folliculitis and pyoderma. Whereas drug of choice for lymphangitis. Lymphangitis is usually due to group A beta hemolytic streptococci, for which even a simple penicillin is more than enough. Penicillin is not available, so we often use amoxicillin. But benefit of doubt, any skin infection, first generation antibiotics such as cephalexin or cefadroxil can be useful. For your entrance question, okay, any lesion in or around the face, okay, can be either impetigo contagiosa, which is due to group A beta hemolytic streptococcus, or bullous impetigo, which is due to staphylococcus aureus. Right? Skin. Next. What is this? What is this? The child is having what? The child is having hydrocephalus. What is this? The child is having hydrocephalus and the child is intubated. What is the most common cause for infantile hydrocephalus? The most common cause for infantile hydrocephalus is aqueductal stenosis. Is aqueductal stenosis, which usually affects boys. Okay, and the manifestation and the inheritance is X-linked. Any hydrocephalus in the infantile period, unless otherwise proved, you need to consider aqueductal stenosis. When hydrocephalus is present with a flat occiput, it can be due to Arnold-Chiari malformation type 2, in which you will get tonsillar herniation. Okay, with flat occiput. When you have a prominent occiput, it is due to posterior fossa cyst, otherwise known as Dandy-Walker syndrome. Dandy-Walker syndrome. Right. When you have a hydrocephalus with diffuse calcification, torch infection, which torch infection will lead to diffuse calcification of the brain, toxoplasmosis. Again, when you have a hydrocephalus with periventricular calcification, then again torch infection, but here it is due to cytomegalovirus. Periventricular calcification, cytomegalovirus, diffuse calcification, toxoplasmosis. Remember, when will you suspect hydrocephalus? If the occipitofrontal circumference, otherwise called as OFC, when occipitofrontal circumference increases more than 1 centimeter per fortnight, which increases more than 1 centimeter per fortnight, consider an evolving hydrocephalus. And one more point, a sutural separation of more than 0.5 centimeter. Sutural separation of more than 0.5 centimeter after 2 weeks also should be considered for hydrocephalus unless otherwise proved. And one more prominent point, whenever you get hydrocephalus with congestive cardiac failure, and congestive cardiac failure, it is due to vein of Galen malformation. Which is due to vein of Galen malformation. Which is due to vein of Galen malformation. right? So this is all about hydrocephalus, large head, occipitofrontal circumference, right? So who is this fellow? Coarse facial features, thick lips. What is this? Coarse facial features. The guy has got coarse facial features, thick lips, and then thick eyebrows. What is this condition called as? This is mucopolysaccharidosis. For you, it is nothing but Hurler syndrome. Mucopolysaccharidosis, Hurler syndrome. Coarse facial features, thick lips, large mouth, large tongue. Because of that, you will get obstructive sleep apnea. So this is mucopolysaccharidosis, otherwise called as MPS. Otherwise called as MPS, comes under lysosomal storage disorder. Lysosomal storage disorder. Let me tell you some important points with respect to mucopolysaccharidosis. Only X-linked is what? Hurler. Hurler or Hunter? Is Hunter. Second, only there are 5 types: 1, 2, 3, 4, and then 6. There are 5 types of mucopolysaccharidosis. The mucopolysaccharidosis all are characterized by 5 features. All are so let me write. So coarse faces, and then mental retardation, corneal opacity, and then hepatosplenomegaly, and then dysostosis multiplex. That is skeletal dysplasia, spine abnormalities, multiplex. So type 1 is Hurler, characterized by everything: coarse facies, mental retardation, corneal opacity, hepatosplenomegaly, and dysostosis multiplex. 2 is Hunter, in which all will be present but mild. All will be present but mild, but there is no corneal opacity. The hunter can hunt because if he has a good vision, he can hunt. Third is Sanfilippo. This is characterized only by mental retardation. There will not be any coarse faces, no corneal opacity, no hepatosplenomegaly, no dysostosis multiplex or spine abnormalities. And then 4 is Marcuse, and 6 is Marotier Lamy. Remember, both are characterized by severe spine abnormalities. Both are characterized by mild or no coarse facies, mild or no mental retardation, mild or no corneal opacity. Excuse me. But so all are same. But how to differentiate between Marcuse and Marotier Lamy? Simple. In Marcuse, there is no hepatosplenomegaly, but Marotier Lamy is characterized by hepatosplenomegaly. This is the simplest way to remember mucopolysaccharidosis. Okay, so any child with coarse facial features, chubby features, thick eyebrows, thickened lips, protruded tongue, corneal opacity, think in terms of mucopolysaccharidosis. All are autosomal recessive except Hunter, which is X-linked recessive. Right. Mental retardation. Tell me the condition which is associated with only mental retardation. Very good. Type 3. Type 3, otherwise known as what? Sanfilippo. Type 3 is Sanfilippo. No corneal opacity is for Hunter. No hepatosplenomegaly is for Marcuse. Okay. Remember, as I told you already, type 4 and type 6 as spine abnormalities. So they are prone for atlantoaxial subluxation. Atlantoaxial subluxation. So before allowing the child to play, you need to assess whether it is prone for subluxation or not. If it is prone for subluxation, the child can prone for sudden death. So what is the screening test of choice for any suspected mucopolysaccharides? Urine for glycosaminoglycans. What? Urine for glycosaminoglycans. Urine for glycosaminoglycans. Yes, this is with respect to mucopolysaccharidosis. Coarse facial features. Right. Periorbital puffiness. What should be the answer, my dear boys and girls? Periorbital puffiness with reduced urine output. What should be the answer? Periorbital puffiness with reduced urine output. Yes, you are correct. It should be nephrotic. Look at this. Periorbital puffiness. Then it is nephrotic syndrome. Nephrotic syndrome is characterized by what? Proteinuria. Nephrotic syndrome is characterized by what? Proteinuria. So what will happen? 24-hour proteinuria is characterized by more than 1 gram per meter squared per day. Which one? Urine albumin. 1 gram per meter squared per day. Serum albumin will be less than 3 grams per deciliter. Most common cause for steroid resistant nephrotic syndrome is minimal change nephrotic syndrome, whereas most common cause for steroid resistant nephrotic syndrome is focal segmental glomerulosclerosis. You can't catch 24-hour urine in a child, so that you are using spot PCR. A spot PCR of more than 2 is characterized as nephrotic range of proteinuria. Spot PCR of more than 2. Urine albumin 3 plus or 4 plus. What will be the color of the plasma? Because of increase in triglycerides and cholesterol, the color of the plasma is milky. Color of plasma is milky. What is the treatment of choice? Steroids. Of choice, steroids. So any child with periorbital puffiness, one more good point is they are also associated with genital edema. Genital edema is very characteristic of nephrotic syndrome. Genital edema is very characteristic of nephrotic syndrome. Okay, it won't occur in nephritic syndrome. Genital edema, right? So this is periorbital puffiness, and the clue is if it is associated with the genital edema, think in terms of a nephrotic syndrome. What is this? The child is very pale. The child is absolutely pale. Look at that. The child is pale. So paleness means iron deficiency anemia. So based on IMNCI guidelines, your iron deficiency anemia can be picked up by 3 means. No palmar pallor means hemoglobin more than 11 grams per deciliter. Some palmar pallor means hemoglobin between 7 to 10.9 grams per deciliter. Severe palmar pallor means less than 7 grams per deciliter. In severe palmar pallor, creases will also be pale. Creases will also be pale. Creases will also be pale. As per IMNCI guidelines, when after 6 months, always you need to give 1 ml of elemental iron twice daily, twice a week, as per IMNCI guideline. Twice a week. That 1 ml contains 20 milligram of elemental iron and 100 microgram of folic acid, 20 milligram of elemental iron and 100 microgram of folic acid. That should be given twice a week after 6 months. Remember, microcytic anemia means less than 70 femtoliter. Most common cause is iron deficiency anemia. MCV more than 100 femtoliter means it is usually macrocytic anemia. Most common is B12 deficiency. Remember, both iron deficiency anemia and B12 deficiency are nutritional anemias, and they are characterized by increased red cell distribution width of more than 15. All nutritional anemias are characterized by a red cell distribution width of more than 15. So some palmar pallor, no palmar pallor, severe palmar pallor. Facial pallor can also be included. What is this? Greenish patch in the lumbosacral region. What is this? This is Mongolian spot. This is Mongolian spot. Greenish patch in the lumbosacral region. Greenish where? Lumbosacral region. Okay. So what is the new name? The new name is simple. What is the new name? It is dermatomal melanosis. Dermal melanosis. Increased melanin pigment. Usually disappears by 6 months to 1 year because it is physiological. 6 months to 1 year. When it is giant and not disappearing means it can be due to GM1 gangliosidosis. It can be due to GM1 gangliosidosis, or it can occur in sialidosis. Both are inborn errors of metabolism. So don't think that each and every time this Mongolian spot is normal. This Mongolian spot, if it is giant and doesn't disappear, think in terms of think in terms of an inborn errors of metabolism. That's all. Okay, again, look at this. The child, what is this child has? The child has rickety rosary. What is the approach to rickets? Rickety, already nutritional rickets were discussed. Let me write an approach to resistant rickets. Always you need to consider phosphorus. Whether the phosphorus is high. If the phosphorus is high, it can be due to chronic renal failure. Okay, if the phosphorus is low, then you need to find out whether parathyroid hormone is high. Parathyroid hormone is, when parathyroid hormone, it can be normal, or parathyroid hormone PTH is high. Parathyroid hormone is high. If phosphorus is low and parathyroid hormone is normal, it is X-linked hypophosphatemic rickets. Hypophosphatemic rickets, for which you need to give phosphorus mainly. Phosphorus. Whereas if PTH is high, if your parathyroid hormone is high along with low phosphorus, then divide into 2. Whether low 25 OHD3, that means it is nutritional rickets. Rickets. If nutritional rickets, then if low, then look for 125 OHD3. Whether it is low or high. Low means vitamin D dependent rickets type 1 due to reduced 1 alpha hydroxylase. Whereas I means it is vitamin D resistant rickets 2. It is characterized by end organ resistance. End organ resistance. And this VDDR type 2 is associated with very, very important alopecia. One clue. Second, X-linked hypophosphatemic rickets predominantly involve your lower limbs. So this is a simple approach towards resistant rickets. And what you had seen just now is rickety rosary. This is a true case of vitamin D resistant rickets type 1. This case. Right? Then, so what is this? Very, very, very easy. What is this? Look at this. There are some hyperpigmentation or there are some scales in the proximal metacarpophalangeal and proximal interphalangeal joint, and this child has been suffering from fever of many days along with proximal muscle weakness. Proximal muscle weakness of upper limb means cannot able to abduct or cannot able to button. Proximal muscle weakness of lower limb means cannot able to stand from sitting position. Okay, so what is this? This is a case of juvenile dermatomyositis. Juvenile dermatomyositis. The rash in the eyelid is called as what? So the rash in the eyelid is called heliotrope rash. Heliotrope rash. Whereas the rash in the metacarpal and proximal interphalangeal joint is called as Gotron papules. Gotron papules. So what is the investigation of choice? The current investigation of choice is MRI tie. Investigation of choice is MRI tie. And it is mainly due to what? Antibody mediated against capillaries. This is juvenile dermatomyositis. Juvenile dermatomyositis. Heliotrope rash means eyes and Gotron papule means knuckles. Juvenile dermatomyositis. Right? Then, yes, what is this? The liver is on the left. Spleen is on the right. Fundus gas bubble is on the right. The apex is on the right. So what is this? Yes, this is a case of situs inversus totalis. Totalis. It is commonly associated with what? Cartagena syndrome. Jenner syndrome, otherwise known as primary ciliary dyskinesia. Primary ciliary dyskinesia. What is the pathophysiology? It is mainly due to ciliary defect. Cilia will not work well, and it is characterized by triad of otitis media, recurrent or resistant otitis media, recurrent sinusitis, and the last point is middle lobe bronchiectasis. And the last point is middle lobe bronchiectasis. Is primary ciliary dyskinesia. Investigation of choice is what? Investigation of choice is ciliary studies under electron microscope or high speed video microscopy. High speed video microscopy. Okay, so situs inversus totalis. Primary ciliary dyskinesia, cartagener syndrome. Okay, right. Yeah, and often asked one. Look at this. I saw this child, 4-year-old child with 𝐒𝐿 What do you mean by that? So this is nothing but precocious puberty. What is the most common cause in girls? It is idiopathic. No cause. When will you say precocious puberty? When 𝐒𝐿 occurs less than 8 years. Okay, whenever you have precocious puberty with retarded bone age, it is usually due to long-standing untreated hypothyroidism. Why? In untreated hypothyroidism, TSH will be very, very high. TSH has got alpha subunit and beta subunit. The alpha subunit of TSH and alpha subunit of LH and FSH are one and the same. So this high amounts of alpha subunits of TSH acts on the ovaries, acts on the uterus to produce premenstrual bleeding. Okay, again, hypo with advanced bone age means precocious puberty with advanced bone age means true precocious puberty. Most common cause, as I told you, idiopathic. When precocious puberty is associated with அங்க லைட் ஆஃப் பண்ண பூச்சி வருது எனக்கு. இப்போ எனக்கு வருது அங்க போடும். When it is associated with the caphulase part, precocious puberty, when it is associated with the caphulase part, then it is called as caphulase part, then it is called as 𝐒𝐿 syndrome. 𝐒𝐿 syndrome. So this is about precocious puberty. Very, very important. Most common cause is idiopathic. Centrally mediated will be associated with 𝐒𝐿, whereas peripherally associated will be associated with only menstrual bleeding. With retarded bone age is hypothyroidism. With caphulase part is 𝐒𝐿 syndrome. Precocious puberty. Right. So what is this? Yes, you have some rashes in sun exposed areas. You have rashes in sun exposed areas. What is this? The answer is very, very, very easy. Sun exposed area rashes. Yes, very good. This is niacin deficiency. This is niacin deficiency. Niacin deficiency. Right. So let's have a small simple clinical things with respect to vitamins. Okay, so this is niacin deficiency, otherwise known as pellagra, rash in the sun exposed areas. So other things, what are all the other questions, picture based questions or other MCQs that can be asked with respect to vitamins? Aphonia in newborn is due to thiamine deficiency. Thiamine deficiency. Aphonia in newborn is due to thiamine deficiency. CCF again due to thiamine deficiency. Pancytopenia can be due to B12 deficiency. MCV more than 100, B12 deficiency. What is avidin? Avidin present in the egg and it retards the absorption of biotin. So you need to boil the egg to get biotin. Boil the egg to get biotin. Okay. Infantile tremor syndrome is associated with B12 deficiency. What is this? A combination of diarrhea, dermatitis, dementia, pellagra, niacin deficiency. Alopecia and developmental delay, again biotin deficiency. Okay, by a peripheral neuropathy, which vitamin deficiency? Pyridoxine. Pyridoxine. Maize eating population, which one will come for maize eating population? Again, pellagra. Population, pellagra. Parafollicular keratosis, vitamin A deficiency. Perifollicular hemorrhages, vitamin C deficiency. Which vitamin is associated with the hemolysis in preterm? Vitamin E. Hemopericardium associated with which vitamin deficiency? Vitamin C. Painful rosary, scurvy, vitamin C. Painless rosary, rickets. Occurs in ricket. These are all some of the small tidbits, one-liners I want to share to my kids. Okay, right. What is this? The what is this maneuver? What he is trying to measure? He is trying to measure mid upper arm circumference. Trying to measure mid upper arm circumference. So it is midway between tip of acromion. Midway between tip of acromion and the tip of olecranon. Tip of acromion and tip of olecranon. Midway between. It is normally fixed between 6 months to 5 years. Less than 11.5, severe acute malnutrition. 11.5 to 12.5, moderate acute malnutrition. More than 12.5 means normal child. Instead of this, what is the tape that we use, which has got green, a yellow, and then a red? That tape is called as Shakir's tape. The tape is called as Shakir's tape. So this is mid upper arm circumference, right? How to measure? Shakir's tape, you remember. Shakir's tape. Right. Very, very important. Shakir's tape, they will give you, it contains three colors. So green, and then one more color is, they will have an yellow color, and then the tape will have red color. If red color means severe, so Shakir's tape, one more thing you need to remember. Right. Next picture. Yes, what is this? The child is having cough hypertrophy. Boy with the cough hypertrophy. Look at this cough hypertrophy. Boy with the cough hypertrophy, unless otherwise proved, is what? Duchenne muscular dystrophy. Less severe form is Becker muscular dystrophy. So, what is the sign when the child is unable to arise from the sitting to standing position? What is that sign called as? Gower sign. Called as Gower sign. Okay, as I told you, severe type is Duchenne muscular dystrophy. Non-severe type is Becker muscular dystrophy. Invariably, any boy comes with proximal muscle weakness, inability to stand or inability to rise limbs, means the first investigation of choice is CPK. It will normally is less than 150 milligram per deciliter, because the muscle undergoes dystrophies and CPK will be released from the muscle. One more important point is they can also present as transaminitis, elevated OTPT, because OTPT can also be released from muscles. Invariably, when a boy comes with only elevated transaminitis, instead of thinking about an abnormal liver disorder, think in terms of a muscular dystrophy. Okay, right. What is the sign I told you? Gower sign. One more sign is called as Valley sign. Valley sign. So what is the investigation of choice? What is the investigation of choice? Investigation of choice is next generation sequencing, RMLPA, to find out the exon deletion. Find out the exon deletion. What are all the new drugs? The new drugs are ataluren. Luren. It doesn't have any steroidal side effects. Please listen. It is called as what? Ataluren. One more drug is called gene splicing agent. Drug is called ertiplursin. Drug is called as ertiplursin. Very, very important. Can be asked. Ertiplursin. Second one is ataluren. Remember what is that I told you, my dear boy? Ataluren. New drug. Another drug is ertiplursin. Ertiplursin. Okay, right. So what we are measuring? So that topic was over. Now what we are measuring, my dear boys and girls? What we are measuring? What we are measuring? What is this called as? Very good. This is called stadiometer. This is called stadiometer. Less than 2 years, we will call it as length, and we measure with the help of infantometer. Whereas more than 2 years, height. And what is this called as? Stadiometer. Meter. Right. What is the normal length at birth? Normal length is 50 centimeter. At 1 year, 75 centimeter. At 2 year, 87 centimeter. And at 4 years, 100 centimeter. Remember, always between 6 to 12 years, a child should have a minimum of 4 to 6 centimeter per year increment. If it is less than 4 centimeter per year after 6 years, then it can be growth or due to growth hormone deficiency, or it can be due to thyroxine deficiency. Thyroxine deficiency. Very, very important. So what is this called? This is called stadiometer to measure the height of the child. Stadiometer. Then next. Oh, milestones. The child is trying to lift the neck. The child is here trying to lift the chin. Chin 45-degree above the level of the ground. Usually occurs by 8 weeks. Then what will happen? Face, neck and chest with flexed forearm. 3 months. Extended forearms in prone position. 6 months. Crawling with abdomen touching the ground. 8 months. Creeping, abdomen doesn't touch the ground. 10 months. And then bear walk by about 12 months. 12 months. 1 second. Online class la irukken. 12 months. Okay. Then pivot, sitting and turning diagonally back towards source of sound. Pivot, 11 months. And then what is this? Cruising around the chair means again 11 months. Cruising around the chair again 11 months. Simple. Some milestones. Again, this we already saw now. No palmar pallor, some palmar pallor, severe palmar pallor. No means more than 11 grams per deciliter. Some means 7 to 10.9. Severe means less than 7. Severe means it involves palmar creases. It involves palmar creases. Okay, right. What is this? As it was already explained to you. What is this one? The first one is cavity. The second one dot thing. Miliary pattern. Third one hilar adenopathy. All these are in favor of what? Favor of what? Tuberculosis. Now will you give antibiotic or you will proceed for CB naught? These are TB specific X-rays. So the next step is CB naught. The next step is CB naught. Okay. The next step is CB naught. Very, very important 3 X-rays for your entrance examination. Okay? Right. Look at this. The child is floppy. The child is floppy. And what is this position? This is called frog leg position. This is called frog leg position. Frog leg position. The child is frog. So, what are all the differential diagnosis for a floppy infant? And the child is intubated because there is no respiratory muscle support. Absent DTR means it is spinal muscular atrophy. Absent DTR means it is loose spinal muscular atrophy. Nothing but like a motor neuron disease of an adult. If anterior onsels are not formed well in pediatrics, it is called as spinal muscular atrophy. Again, tongue fasciculation, spinal muscular atrophy. Foot drop means peripheral neuropathy. Most common cause Charcot-Marie tooth disease. Tooth disease. Most common cause for hereditary neuropathy. Again, in pediatrics, Charcot-Marie tooth disease. Okay, most common muscular dystrophy. Just now we saw Duchenne muscular dystrophy. Fatigable weakness. What do you mean by fatigable weakness? I can speak like this is called fatigable weakness. Suggestive of neuromuscular junction disorders. Diagnosis myasthenia gravis. Myasthenia gravis. What is this drug? Nusinersen. I taught you one new drug, ataluren, etiplirsen. In the same way, what is called nusinersen? It is used in spinal muscular atrophy. Other name is called as Spinraza. Other name is called as Spinraza. Other name is called as Spinraza. So this is a basic approach to floppy infant. Right. What are all the 2 vaccines that are stored in brown bottle which are extremely photosensitive? One is MMR, another is BCG. So one is MMR, next one is BCG. What is the vaccine that is stored in freezer? The only vaccine that is stored in freezer is OPV. Oh, then first compartment, next compartment BCG, MMR. The middle compartment, all vaccine that starts with T. Lower compartment is hepatitis B, varicella. Varicella. At birth, you give OPV, BCG, hepatitis B. 6 weeks and 14 weeks, same OPV, IPV, intradermal, pentavalent, PCV, and then rotavirus. Rotavirus. 6 and 14 weeks. 10th week, OPV, no IPV, pentavalent yes, no PCV, rotavirus yes. 9th month is OPV, JE, MR booster, PCV booster, and right now they had included intradermal IPV. 15 to 19 months, DPT booster, OPV, and then JE, as well as MR2. At 5 years, DPT, capital D, capital P, capital T. At 10 years, TD. Okay, yeah, short revision. Okay, what else I can offer you? Right. What is this? What is this? White curdy. precipitates in the mouth. What is this? This is oral candidiasis. This is oral candidiasis. It can be due to bottle feeding, or it can be due to T cell defect, or it can be due to HIV if it is persistent oral candidiasis. What? If it is persistent oral candidiasis. What is this? Yeah, hair over. What is this? Hair over central spine. Spina bifida occulta means no meningeal protrusion, no nerve protrusion. Meningocele means only meninges. Meningomyelocele means meninges and then spinal cord. Most commonly associated with what? Most commonly associated with Arnold Chiari 2. Chiari 2. What is the prevention mode of management? 0.5, 0.4 milligram is primordial prevention without any risk factor. Whereas when there is already affected child means 4 milligram in periconceptional period. Periconceptional period. What is this? What is this? Clubbing. Clubbing grade 1 means softening of nail bed. What is grade 2? Grade 2 is Shamroth sign. Grade 2 is Shamroth sign, or low V bond angle more than 80 degree, or loss of this diamond space. Shamroth sign is loss of diamond space. Grade 3. This one is grade 3. Grade 3. Parrot beak or drumstick. Grade 4. Hypertrophic osteoarthropathy. What is grade 4? Hypertrophic osteoarthropathy. Right, remember, can anyone tell me what is the cause for unidigital clubbing? What is the cause for unidigital clubbing? Unidigital clubbing. Unidigital clubbing means trauma. What is the cause for unilateral clubbing? Only one hand is involved. Unilateral clubbing. Two causes. One is median nerve injury. Another one is subclavian artery aneurysm. Subclavian artery aneurysm. This is about clubbing. Then what is this with respect to milk? What is this? So can you tell me what is this? So first part of milk is called foremilk. First part of milk is called foremilk. It is rich in water, so it clinches thirst. Watery. Second part is called as hind milk. Hind milk is rich in nutrition. So it quenches thirst. First week of breast milk is called as colostrum, yellowish color. It is rich in immunoglobulin. It is the first vaccine, I can say, that we can give to the mother. First week. Breast milk contains more, remember, lactose. Whereas cow milk contains more proteins. Breast milk contains more carb. Cow milk contains more protein. Fat is equal in both. Milk can be stored in room temperature for 6 hours. Okay, right. What is this? Black colored urine on standing. What is this? Black colored urine on standing. Yes, alkaptonuria. Black colored urine on standing. Alkaptonuria due to deficiency of homogentisic acid oxidase. Alkaptonuria, homogeneous. What is the treatment? The treatment, what is the treatment? Vitamin C. One more treatment for alkaptonuria is, tell me, what is the other treatment for alkaptonuria apart from vitamin C? Nitisinone. What is that? Nitisinone. Black colored urine on standing is alkaptonuria. What is this? To a 10-year-old girl brought with fever, cough of more than 2 weeks along with weight loss. Look at this. Is this TB specific or non-TB specific? There are numerous cavities. There are numerous cavities. So cavity means suggestive of TB. So what is this? Next investigation of choice is CB naught. So this is multiple cavities. TB specific. Right? Okay. Let me show you a video, my dear boys and girls. Video session. Simple. For 1 second. Video. Where is that video? Sorry. So identify this cough. Identify this cough. What is this cough called as? Identify this cough. What is this called? A cough, breath, cough, breath, cough, breath. So this is called as what? This is called as staccato cough. What is this cough? This is called as staccato cough. Okay, this is called staccato cough. Suggestive of chlamydia. Suggestive of chlamydia. Okay, then what else I can show you? Videos. Okay, assess the dehydration of this child. Assess the dehydration of this child. Assess the dehydration of this child. What is the skin pinch? Goes back very slowly. Skin pinch goes back very slowly. What is this? This is a case of severe dehydration. This is a case of severe dehydration. Skin pinch goes back slowly. Okay, right. And unfortunately, one video. 1 second. Let me try to show you a video. 1 second. One second, let me try to show you a video. Yes, got it. Yes, I'm going to show you one more video. Yes, got that video. I'm extremely sorry for that. Look at the child. Look at how the child is coughing. Look at the child, how the child is coughing. Look at this. What is this? The child is coughing like anything. What is this? Let me play again. What is this? The child is coughing like anything. Cough, cough, cough. And the child is getting what? Tears from eyes and redness of face. This is pertussis. Paroxysmal, post-acute vomiting, inspiratory whoop, and redness of eyes and tears from eyes is called as pertussis. Drug of choice, it is caused by Bordetella pertussis, and drug of choice is macrolide. Drug of choice is macrolide. So this is pertussis. So severe dehydration I had shown you. So what is this sign? What is this? What is this? This is monkey faces. This is, what is this? Monkey, this is baggy pant appearance. Baggy pant appearance, both suggestive of marasmus in severe acute malnutrition. Okay, what is this? This is called black sign, alternative pigmentation and depigmentation, and this is called flaky paint dermatosis. Flaky paint dermatosis. Flaky paint dermatosis, suggestive of kwashiorkor, protein loss, protein deficit. Okay, flaxine, alternative pigmentation and depigmentation. Okay, what is this newborn condition? Newborn condition. This is Epstein pearls. Epstein pearls in the palate. Under red erythematous rash. Red erythematous rash in newborn. All are newborn. Newborn. Red newborn. This erythematous rash is called Epstein. I am sorry, is called as what? What is that? Red erythematous patch. So Epstein pearls. So what is this? Woodening of. This is called scleroderma. This red patches is called erythema infectiosum. This is benign. This is benign. Scleroderma is woody induration due to gram-negative sepsis. This is pathologic. Pathologic. Okay. So what is this? Two-thumb technique. Two-thumb technique should be used. What is this? This is called laryngeal mask airway. So what is this position called as? See, these with respect to newborn respiration. What is this called as? Sniffing position. Sniffing position. And what is this? And this is called as CPAP. These are some of the newborn conditions that will be asked. So what is this? Spina bifida. Spina, what is this? Not spina bifida. This is meningocele. Meningocele due to deficiency of zinc, folic acid. Hyperpigmentation of knuckles is due to B12 deficiency. Alopecia with developmental regression is suggestive of biotin deficiency. Suggestive of biotin deficiency. Okay, biotin deficiency. And finally, what is this? Moro reflex. Starts by 28 weeks and then matures by 34 to 36 weeks, disappears by 3 to 6 months. Moro reflex. What is this? Patch. This is diphtheria. This is diphtheria. It can also occur in infectious mononucleosis. It can also occur in group A beta hemolytic streptococcus. These two don't bleed. But diphtheria bleeds when on removal. Diphtheria bleeds on removal. When someone is asking what is the drug of choice for diphtheria, the drug of choice is antitoxin. The drug of choice is antitoxin, right? So again, this Gower sign, it was explained to you. Gower sign explained to you occurs in Duchenne muscular dystrophy. Staccato cough caused by chlamydia. What is this? Herpes zoster dermatomal distribution. Herpes zoster dermatomal distribution. Herpes dermatomal distribution. Abdominal distribute. Okay. Yes. What is this? Potter. Fast. Be fast. 3-month-old child. Persistent tachypnea since birth. Look at this. Emphysematous lung. Little bit of collapsed lung. Mediastinal shift to the right. This is congenital lobar emphysema. Often asked question now. Congenital lobar emphysema. Very, very commonly asked in inset. Congenital lobar emphysema. Air entry will be reduced over that area. Air entry will be reduced. Right. So what is this? New 2 days old respiratory distress, cystic lesions in one lung. What is this? Very good. This is congenital diaphragmatic hernia. Suspect when any child with distress and scaphoid abdomen. Distress with scaphoid abdomen. This is congenital diaphragmatic hernia. Right? So what is this? Massive cardiomegaly. Money bag heart, large heart, suggestive of what? Pericardial effusion. Pericardial effusion. If it is associated with fever, it can be due to TB pericarditis, money bag appearance. What is this? See, this massive cardiomegaly is not associated with pulmonary vascular markings, whereas this one is associated with enlarged pulmonary vascular markings. So, large heart with increased pulmonary vessels means it is congenital heart disease. It can be AST, VST, or PDA. Anything can be possible. Okay. Yeah, if it is pansystolic murmur means VST. Pansystolic murmur means VST. What is this? 4-month-old child, floppy infant. What is the diagnosis? Can anyone tell me? Remember, whenever you have a combination of floppy infant, massive heart, floppy infant, massive heart, think in terms of Pompis disease. Due to what? Acid maltase deficiency. Acid maltase deficiency. Right? Then what is this? So pulmonary oligemia, because no vessels are seen. What is this? Boot-shaped heart. So what is the diagnosis? Tetralogy of Fallot. Tetralogy of Fallot. Any child newborn with cyanosis. Tetralogy of Fallot, money back-shaped heart. What is this? What is this? 3 days old, no murmur, sudden onset sinus. This triad is unless otherwise proved of what? Transposition of great arteries. I repeat, transposition of great arteries. Okay, this is egg on side heart. Egg on side heart. Transposition of great arteries. Egg on side heart. So what is this? Whenever you have strawberry tongue, strawberry tongue and peeling, skin peeling, along with fever, along with cervical node, it is always Kawasaki disease. Remember, whenever strawberry tongue is given along with the peeling of skin, it is Kawasaki disease unless otherwise proved. It is unless otherwise proved. Finally, some more milestones. Okay, descending down. She is descending down. When she uses both foot per step, 2 years. Alternative foot up, 3 years. Alternative foot down, 4 years. So she must be 4 years. Jumping, 2 years. Hopping, 3 years. Skipping, 5 years. Skipping, 5 years. Finally, crawling. Crawling, 8 months. Creeping, 10 months. Bear walk, 12 months. Bear walk, 12 months. This child is abdomen off the ground. So she is creeping. Abdomen off the ground. She The child is creeping. And finally, she is turning diagonally back. What is this? Pivot. Pivot by 11 months. Sitting with support 6 months, without support 8 months. Cruising around the chair 11 months. Standing alone 12 months. Walking alone 15 months. 15 months. This is pivot. Very, very important. This is pivot. Turning diagonally back towards sound. This is pivot. So what is this? Finally, urine color. Bright red urine means lower urinary tract from pelvis. Cola colored urine means glomerular hematuria. Asymptomatic recurrent hematuria occurs in IgA nephropathy or thin basement membrane disease. This is cola colored urine. Cola colored urine suggestive of acute glomerulonephritis. When hematuria occurs following diarrhea, it is hemolytic uremic syndrome. Whenever you have a combination of anemia, microangiopathic hemolytic anemia and schistocyte, again hemolytic uremic syndrome. What dye can produce phenolphthalein? Red urine, phenolphthalein. What drug? Rifampicin. Rifampicin all can produce hematuria. So thanks for your patient listening. Well done. So you have been with me for the past almost, we are going to touch 2 hours, just 5 minutes more. This PDF will be uploaded right now. Bye bye. Thanks for patient listening. Love you all.